Good day, everyone. So today we'll be looking into pancreatitis. So this is basically a condition that affects the pancreas and can have serious health conditions. So we will cover the pathogenesis, the causes, the clinical manifestations, the prognosis, and chronic pancreatitis. So let's begin to understand what really pancreatitis is. So, pancreatitis is an inflammatory condition of the pancreas that can be acute or chronic. The pancreas plays a vital role in digestion and blood sugar regulation, and when there's inflammation, it can impair the same functions. Acute pancreatitis occurs suddenly and is often reversible, while the chronic pancreatitis develops over time, leading to permanent damage. The most common causes of pancreatitis include gallstones and excessive alcohol consumption, but there are many other contributing factors. The severity of pancreatitis can range from mild discomfort to life-threatening complications. So now let's look at how pancreatitis develops. The main issue is axonal cell injury, which leads to the premature activation of pancreatic enzymes. So normally what happens is that these enzymes, they help digest food in the small intestines. But when they are activated, early, they begin digesting the pancreas, causing autodigestion. And this would lead to fat necrosis, tissue damage, and inflammation. The causes of axonal cell injury vary, and they include direct toxicity from the liver, from alcohol or drugs, impaired enzyme secretion due to duct obstruction, and ischemia from reduced blood supply. So the body will respond with an intense inflammatory reaction, which can further exacerbate the damage. So you can see that on the diagram, we have an acute injury, and this acute injury would lead to an initial insult. And this initial insult would lead to a variety of things. It can lead to the release of active enzymes. It can lead to the release of vasoactive substances. And it can also lead to the generation of cytokines like tumor necrosis factor, interleukin 1, interleukin 6, and 8. And these interleukins, they lead to inflammation, and they can also lead to vascular damage. And some initial insults like ischemia or duct obstruction, they can lead to the release of vasoactive substances, and all of this can lead to vascular damage. So when we have vascular damage, when we have inflammation, and when we have the release of these active enzymes, they will now lead to tissue damage and cell death. So this is how pathogenesis of pancreatitis comes about. Now, let's dive deep to now look into the etiology of pancreatitis. So, pancreatitis has multiple causes, and these are classified into different categories. The most common cause is gallstones. We can see that for the gallstones, they account for about 40% of the cases. And then small stones or microlithiasis can obstruct the pancreatic duct, leading to inflammation. Remember the pathogenesis. And the second one is alcohol at 30%. So alcohol is responsible for around 30% of the cases, as I've already said, and mostly is chronic alcohol that can lead to recurrent episodes of pancreatitis. So these are the two main causes that you should never ever forget as a medical student: gallstones and alcohol. Then the others include certain medications like diuretics, like ACE inhibitors, like valproic acid, as well as some metabolic disorders like hypertriglyceridemia and hypercalcemia, and even infections like mumps, like Epstein-Barr virus, tuberculosis, they can trigger pancreatitis. Also, autoimmune conditions like ischemia from blood vessel disorders, trauma, and even genetic mutations can also contribute. We also have post-ERCP pancreatitis can occur after maybe an endoscopic procedure, and rarely scorpion stains have been linked to pancreatitis, particularly in Trinidad. Now, let's look into how pancreatitis manifests. So the most common symptoms is severe epigastric pain, and it often radiates to the back and worsens after eating. So patients may find some relief by leaning forward. Other symptoms include nausea, vomiting, fever, and jaundice if the bile flow is obstructed. And severe cases may include hypotension, you may have shock, and some signs of retroperitoneal hemorrhage, such as the Cullen signs, which is basically the bruising around the umbilicus, and the Gray-Turner sign, which is bruising that happens along the flanks. So since pancreatitis can mimic other conditions like gallbladder inflammation, peptic ulcer, or aortic aneurysms, a proper diagnosis is required for pancreatitis. So these are some of the clinical manifestations that I've already said. Some we have cyanosis, we have pale skin, this same pain that radiates to the back, you have a rapid pulse, and so on. So looking at the diagnostic studies, so to diagnose pancreatitis, we rely on laboratory tests and imaging studies. So blood tests reveal that you will have an elevated amylase and lipase levels, with lipase being more specific. So if the ALT is more than 3 times the normal level, gallstone pancreatitis is most likely. So I will repeat that. You should know this at the back of your head. If ALT is more than 3 times the normal level, gallstone pancreatitis is likely. Then other lab findings include increased white blood cells, higher blood glucose, and low calcium levels. So imaging also plays a very crucial role. We look into a CT scan, and it's normally a gold standard for assessing pancreatic inflammation and complications. So ultrasound is useful also for detecting gallstones, but the pancreas is often obscured by bowel gas. MRI and MRCP, they also help to assess pancreatic necrosis and ductal issues, while endoscopic ultrasound can identify microlithiasis if you have a suspected case. Diving forward into the management of pancreatitis, it primarily involves supportive care, and the key components include fluid resuscitation. So you find that in severe cases, we require aggressive IV fluids, sometimes up to 10 liters per day, to maintain circulation and prevent organ failure. We also dive into pain management. You give IV opioids like morphine, hydromorphone, or meperidine. They're also used for pain relief. Then nutrition, there's early enteral feeding, and is normally preferred over the total parenteral nutrition, as this can reduce infection risk and improve the outcomes. And you also give antibiotics, but these are controversial and they are usually reserved for cases with infected necrosis. There's also ERCP and surgery. So if the pancreatitis is due to gallstones causing bile duct obstruction, ERCP with sphincterotomy is performed. And then infected necrosis often requires surgical debridement and gallstone removal is recommended after recovery. So if pancreatitis is left untreated, it can lead to severe complications. So some of the systemic complications that we have shock, we have acute respiratory distress syndrome, ARDS, we can have renal failure, we can have disseminated intravascular coagulation, DIC, and we can also have GI hemorrhage. Then some metabolic complications, we have hypocalcemia, like I said, we have hyperglycemia and hypertriglyceridemia. And one of the local complications is that we can have acute fluid collections, we can have pseudocytes, and we can have an infected necrosis. So I want to talk more on pseudocytes. So you find that for pseudocysts, so for pseudocysts, they may persist for weeks and they require drainage if they are symptomatic. And for infected pancreatic necrosis, this one is basically a severe complication, so it requires antibiotics and surgical intervention. And then for pancreatic abscesses or ascites or pleural effusion, they may also develop and they require draining as well as stenting. So what is the prognosis? So the prognosis of pancreatitis depends on the severity. So mild cases resolved with supportive care, but severe pancreatitis can lead to multiple organ failure. So various scoring systems can predict this severity. So we have the HAPS, which is harmless acute pancreatitis score. So this one, if there's no abdominal tenderness and there is normal hematocrit and creatinine levels, then the cause is likely mild. And we have the BISAP score. So this one is for factors including high blood urea, nitrogen, altered mental status. You have the SARS criteria. You can also have age over 60, and you can have also pleural effusion. So they can predict mortality risk. You can also look into the Ranson's criteria and the Apache 2 score. So they assess the disease severity with higher scores correlating with higher mortality rates. So early intervention and intensive care normally improve survival rates. Looking into chronic pancreatitis, it results from prolonged inflammation leading to fibrosis and loss of pancreatic function. And alcoholism is the leading cause. But autoimmune conditions and genetic mutations, they normally play a role in causing chronic pancreatitis. The symptoms for chronic pancreatitis include recurrent epigastric pain, nausea, vomiting, and in later stages, you can have steatorrhea and weight loss due to exocrine insufficiency. Over time, patients may develop diabetes due to endocrine insufficiency. And the diagnosis normally involves studies like CT scans, MRCP or ERCP, which can show ductal abnormalities, strictures, and calcifications. And the treatment for chronic pancreatitis normally focuses on pain management, a low-fat diet, pancreatic enzyme replacement, and in some cases we can do a surgical intervention to relieve ductal obstruction. So that is pancreatitis. So just to sum it up, we looked into the pathogenesis of pancreatitis. We say there's axonal cell injury via direct or indirect toxicity that would lead to the release or impaired secretion of enzymes, leading to autodigestion, leading to fat necrosis, and there will be a profound acute inflammatory response. And we delved into etiologies. We said the most common cause is gallstones at 40%, and it is usually small stones that are less than 5 millimeters. And we also mentioned alcohol, saying that it contributes 30%, and it is usually chronic. And we talked about other factors like drugs, like metabolic disorders, infections, autoimmune disorders, ischemia, and so on. We also went on to talk about the clinical manifestations. We talked about epigastric abdominal pain that radiates to the back. We talked about nausea, vomiting, and so forth. And during physical examination, when you want to assess pancreatitis, there's normally abdominal tenderness and gagging. There's reduced bowel sounds. There can be a palpable abdominal mass, and you can see jaundice if there's any biliary obstruction. There can be fever, there can be tachycardia, there can be hypotension. So these are basically the physical examination. When you are doing your physical examination, these are the things that you're going to see. And we went on to talk about some diagnostic studies to say that laboratory-wise, there's an increase in amylase, and normally it's more than 3. And there's also an increase in lipase and other tests. Then for treatment, we said supportive therapy in mild cases is usually sufficient. You can do fluid resuscitation. There's nutrition, where we prefer enteral nutrition. You can give analgesics. You can give some prophylactic systemic ABX and surgery if it's that severe. Then we went on to talk about some complications. We looked into systemic complications like shock, like ARDS, renal failure, GI hemorrhage, and DIC, and some metabolic ones like hypocalcemia, hyperglycemia, and we also looked into ascites, pseudocyst, and so forth. So that is pancreatitis. So pancreatitis is a very serious condition that requires prompt diagnosis and management. And for acute pancreatitis, is often reversible with supportive care, while chronic pancreatitis leads to long-term complications, including diabetes and malabsorption. And it is very vital to identify the underlying causes, such as gallstones or alcohol use, and it is essential for prevention and appropriate treatment. So understanding this topic will help you to improve patient outcomes and reduce the discussed complications. Thank you for your time, and I am happy to take any questions. You can post your questions on the comment box, and don't forget to like and subscribe to this channel. Dr. T. Ken is your guy. We call it a day.